Well, hello everyone. So in this presentation, I will discuss the rationale behind doing a study on statins. I will describe the study design and methodology. I will present the results on the prescription of statins and its associated effect on survival and life expectancy at different ages. I will discuss the implications for an individual, for medicine and public health, and for insurance and national policies. I will also give research recommendations. And finally, I will give an overview of the research team's future plans. After the presentation, there is time for questions. So cardiovascular disease is an umbrella term for diseases of the heart or blood vessels, such as heart attack and stroke. It is the leading cause of death in the world, accounting for 33% of the deaths. The underlying cause of CVD is in most cases atherosclerosis, which is a buildup plaque on the walls of the circulatory system caused by excess cholesterol. Most of the cardiovascular events could potentially be prevented by pursuing a healthy lifestyle, including being more active, having a healthy, varied diet, having a healthy body mass index, consuming alcohol in moderation, and abstaining from smoking. These healthier lifestyle choices are promoted using national strategies. Besides lifestyle choices, other modifiable risk factors of CVD are hypertension and hypercholesterolemia. These two risk factors are addressed at the individual level by offering antihypertensive or lipid-lowering drug therapies such as beta blockers or statins, respectively. For primary prevention of CVD, statins could be prescribed. Prescription of the drugs is based on the estimated 10-year risk of a first cardiac event. If the estimated risk is higher than the threshold, the drug is recommended to be prescribed. On the slide, you see an image of the Q-RISK-2 calculator that estimates the risk of a cardiac event. The main driver of the risk is age. The calculator is limited to ages 25 to 84. This is because when you are younger than 25, the cardiac risk is almost 0%. And when you're older than 84, the cardiac risk is at such a level you would in theory always benefit from taking statins. For this webinar, I calculated my risk of having a cardiac event within the next 10 years, which was 0.1%. This means that in a crowd of 100 people with the same risk factors as me, none of us are likely to have a heart attack or stroke within the next 10 years. So that's good news for me. The National Institute of Health and Clinical Excellence is a UK national body that, among others, provides guidelines on prescription of drugs. In 2014, the Institute lowered the threshold at which to prescribe statins from 20% to 10% cardiac risk. This translated to an increasing number of people being eligible for the drugs. That is, an additional 4.5 million UK residents, resulting in a total of up to 17 million people. This stirred up the debate about whether prescribing the drugs to lower-risk patients is effective, other than shifting the risk of death from one disease to another. Clinical trials consistently showed that statins lower the risk of a cardiac event. The lowered risk threshold at which to prescribe statins was mainly based on a study done by the cholesterol treatment trialist collaborators. The study was a meta-analysis on 27 randomized control trials. The study found that in patients with no history of vascular disease, statins reduced the risk of all-cause mortality by 9%. However, the study could not conclude a survival benefit for the individual risk groups due to the small number of cases. Translating the benefits of statins in absolute numbers and focusing on cardiac events instead of mortality as outcome, if there were 100 people with a 10-year cardiac risk of 10%, then on average 90 people will not develop cardiovascular disease, whether they took statins or not. 6 people will develop the disease, whether they took statins or not, and 4 people will be saved by taking statins. There are some limitations of the statin trials. Clinical trials have a high internal reliability, but may be poorly generalizable to the general population that is treated in routine clinical practice. Clinical trials tend to have selection bias, as they are likely to examine the effects of a drug on the ideal patient. With the CTT, meta-analysis, some of the trials excluded older patients, patients with comorbidities, and patients on multiple drugs. Excluding these people will most likely have overestimated the benefits of statins. Furthermore, the follow-up time of each trial was at most 5 years, which is very much shorter than treatment times in routine clinical practice. Lastly, there is a lack of transparency due to the statins trials data not being available for independent scrutiny. This is in particular concern because statins are among the most widely prescribed drugs globally. A large observational population-based cohort study could fill these gaps and be an important new source of information and the possible survival benefits of statins in routine practice. This led to the following research question: what is the survival benefit of statins as primary prevention of cardiovascular disease for different risk groups at various ages in the general population? The results were published in PLOS ONE, and you see here on the slide the reference to that paper. So the research question was addressed by a retrospective cohort study design. For this study, data from the Health Improvement Network primary care database were used. The database currently holds 12 million patient records from roughly 600 general practitioners' practices. This corresponds to 6% of the UK population. The patients included in the database are representative of the UK population with regards to demographics, prevalence of medical conditions, and mortality rates when adjusted for deprivation. The university's data cut was restricted to medical records from 1987 to 2011 of people who are born between 1920 and 1940. From this data cut, 4 cohorts consisting of patients who turned the target age between 1987 and 2011 were created. The target ages were 60, 65, 70, and 75, which are key ages of initiating statin uptake in the general population. Patients with a history of cardiovascular disease were excluded from the analysis. The effect of statins on survival was estimated by a Cox proportional hazards regression. This type of regression is typically used for time to event data. The regression produces hazard ratios, which are the increased or decreased hazard of premature death in one subgroup of patients compared to the other subgroup of patients. Thus, with statins, we would compare the hazard of premature death in patients prescribed statins compared to patients not prescribed statins. All-cause mortality was used because other studies have showed the protective effect of statins on the risk of cardiovascular events and cardiovascular deaths, but it was still unclear what the overall survival effect is. All-cause mortality is not only an important outcome for patients, but also for the national economy. Life expectancy directly affects taxation, national insurance rates, retirement planning, pensions, and actuarial products such as life insurance and annuities. Separate models were developed for each age and for each cardiac risk group. The ages were 60, 65, 70, and 75. The cutoff values for the risk groups were the current and former risk threshold at which to prescribe statins. Thus, the risk groups consisted of patients with a cardiac risk of smaller than 10%, 10 to 20%, or 20% and greater. A common problem with observational data is incomplete records. Here there were missing data in body mass index, smoking status, and the risk of a cardiac event. Incomplete medical records were dealt with by multiple imputation. This allows patients with incomplete data to still be included in analyses and makes full use of all available data, thereby increasing the power and precision. The imputation technique involves creating multiple copies of the data and then replaces missing values with imputed values based on a suitable random sample from their predicted distribution. The goal of multiple imputation is to make valid statistical inferences by reflecting the uncertainty in missing data. table on the slide provides some information about the age cohorts. The sample size ranged from 120,000 to 250,000 patients. Patients were followed up for maximum 24 years. Each age cohort had between 1.1 and 1.9 million person-years of data. The table on this slide presents the percentage men or women in each risk group at each age. It also presents the prevalence of statin prescription in each age risk group. The summary statistics on statin prescription in the table were affected by calendar year, which I will show a figure of later in the presentation. The second row of the table shows that at age 60, 16% of the men were at low cardiac risk. In other words, they had a Q-risk-2 score of less than 10%. Of these 60-year-old men at low cardiac risk, 0.4% were prescribed statins. For women, 83% were at low cardiac risk at age 60, and of these women, 1.2 were prescribed statins. In general, men had a higher cardiac risk than women given age. With the new guidelines, by the age of 65, all men, and by the age of 70, all women in the study were eligible for statins. With the previous guidelines, it would be by the age of 75 for men and by the age of 80 for women. Given risk group and calendar year, statins were prescribed less in men and in older participants. This slide shows a forest plot with the unadjusted and adjusted hazard of all-cause mortality associated with statin prescription. The adjusted effects took into account several medical conditions, treatments, lifestyle choices, and demographic factors. These confounders were found through backward elimination. For those people who are unfamiliar with forest plots, I will explain how to interpret them. Here, the first column presents the age risk groups. The other columns present the unadjusted or adjusted hazard of all-cause mortality associated with statin prescription compared to no prescription, and the confidence interval of that hazard ratio. The hazard ratios are depicted by the boxes. The bigger the box, the more patients in the age risk group. The confidence intervals are depicted by the horizontal lines. The vertical line is at the hazard ratio of 1. In other words, it's the line of null effect, where there is no difference between prescription and no prescription of statins. Any confidence intervals that crosses the null effect line does not illustrate a statistically significant result. Hazard ratios smaller than 1 favors statin prescription, and hazard ratios greater than 1 favors no statin prescription. Focusing on the adjusted effects, in patients with a cardiac risk lower than 10% at any age, or in patients younger than 60 at any cardiac risk, statin prescription was not associated with the survival benefit. In patients with a cardiac risk of 10 to 19% and aged over 60, statin prescription was associated with uncertain survival benefit. In patients with a cardiac risk of 20% or higher and aged over 60, statin prescription was associated with a significant survival benefit. The hazard of mortality was reduced by 14 to 18% in these patients. There were no interactions found with statin prescription. This means that the potential survival benefit associated with statin prescription was experienced the same for various subgroups of patients, such as for men and women. Using Gompert's model, the increase in annual hazard of mortality associated with aging 1 year is approximately constant between ages 30 and 95. For England and Wales in 2010 to 2012, the increase in the hazard between those ages was approximately 1.1. Based on this information, a hazard ratio can be translated to the number of years lost or gained in effective age by dividing the log hazard ratio by the log increase in annual hazard of mortality associated with aging 1 year. In other words, it's dividing the log hazard ratio by the log of 1.1. Using the UK life tables of 2010 to 12, the numbers of years lost or gained in effective age can be translated into the average period expectation of life at the effective age. Variables that are associated with an increased hazard of mortality translate in a higher effective age and therefore a lower period expectation of life. In contrast, variables that are associated with a decreased hazard of mortality translate to a lower effective age and therefore in a higher period expectation of life. The table on this slide presents how the hazard ratios associated with statin prescription are translated to the number of years change in effective age and period life expectancy. The statistics are only provided for the age risk groups where statin prescription was associated with uncertain or significant survival benefit. For example, people with a cardiac risk of 10 to 90% at age 70 would have on average 1.17 years reduction in their effective age if they were prescribed statins. The reduction in effective age results in an increase of life expectancy of 0.85 years for men and of 0.93 years for women. In general, people with a cardiac risk of 10% or greater at age 70 or 75 would on average live 1 to 2 years longer if they were on statins prescription by those ages. The figure on this slide presents the prescription rate of statins in the studied age cohorts over time. It shows that the prescription rate increased considerably over the years. In people with a cardiac risk of 20% or greater, prescription increased from 0% in 1987 to 47% in 2011. Given the risk group and calendar year, the prescription was lower in older patients. With the previous slides, I explained the possible impact of statins prescription for an individual. With the current slide, I will explain the possible impact of statin prescription on national level. Based on the statin prescription rate in each cardiac risk group, the prevalence of these groups, and the change in period life expectancy associated with statins prescription in these groups, the effect of statin prescription on a national level can be calculated. The table on this slide presents the prevalence of statin prescription in each sex-age risk group in 2010. The statistics are only provided for the age risk groups where statins prescription was associated with uncertain or significant survival benefit. In 2010, of men aged 70 with a cardiac risk of 10 to 90%, 18% were prescribed statins. Of men aged 70 with a cardiac risk of 20% or greater, 44% were prescribed statins. At this age, 17% of men had a cardiac risk of 10 to 90%, and the remaining 83% had a cardiac risk of 20% or greater. Additionally, statins prescription was associated with an increase in period life expectancy of 0.85 years in the 10 to 90% risk group and of 1.36 years in the 20% or greater risk group. Using these statistics for men aged 70 with the 2010 prescription rates, the national period life expectancy increased by 0.5 years. If all these men would have been prescribed statins at that age, the national period life expectancy would have been increased by 1.3 years. For women aged 70 with the 2010 prescription rate, the national period life expectancy increased by 0.3 years. If all these women would have been prescribed statins, the national period life expectancy would have been increased by 1 year. For men aged 75, the national life expectancy increased by 0.6 years with the 2010 prescription rate, and would have been increased by 1.3 years if there was a 100 prescription rate. Similarly, for women aged 75, the national life expectancy increased by 0.6 years with the 2010 prescription rate, and would have been increased by 1.5 years if there was a 100% prescription rate. So what do these results mean to the public? Well, the results suggest that the current recommended threshold for statin therapy for primary prevention of cardiovascular disease in routine practice is too low. This may lead to overtreatment, particularly of people under 60 or at low risk of a cardiac event, that is, lower than 10% Q risk 2 score. Clinicians may want to use this new information when discussing the risks and benefits of statin initiation with their patients. Further research is needed on the effects of statins over the long term for younger patients at low cardiac risk. Also, access to the clinical trials data would allow to replicate the study and compare the results. The results showed that statins are associated with increased life expectancy in certain age and risk groups. With widespread statin prescription at retirement ages, this is a factor that should be considered in national policies and actuarial products. Also, individuals might be interested in information on average life expectancy. This information can be used in financial planning for retirement. It can also help them better understand the risks associated with certain lifestyles and how these risks can be lowered by changing their lifestyle. The research team is planning to engage the public directly with the results of this research. This might allow them to advocate for themselves in consultations with their doctors on whether or not to take statins. This might also make them become more aware of the impact of lifestyle and health choices on life expectancy. Another plan is to develop a multi-state survival model for statin prescription. The model will have the following states. At state 0, patients are not eligible for statins. At state 1, patients are eligible for statins. At state 2, patients are prescribed statins. And the final state is death by any cause. Patients could move consecutively through the states. Patients could also move from any state to the final state. And patients could move back and forth between state 1 and state 2. This model allows for changes in statins prescription over time and might more accurately reflect the effect of statins on survival. This was the end of the presentation. Thank you for listening. There's now time for questions, but also feel free to contact me on l.gitsels@uea.ac.uk. Thank you.
Thanks, Lizanne. We haven't had any questions just yet. As Lizanne says, if you do have any questions, please do let us know. Do you have anything that you would like to discuss in the meantime, Lizanne?
I have to think about that, I'm sorry.
That's okay. If that's everything, then that's fine. The webinar will become available online if anyone would like to watch it back. And as Lizanne says, if you do have any questions, please do contact her. So thank you, everybody, and thank you, Lizanne.
Thank you.